Welcome to Forum Fest, the Westminster Town Hall Forum's new summer series that engages the public in reflection and dialogue on important issues of our day. My name is Tim Hart Anderson. I'm the senior minister at Westminster Presbyterian Church, located on Nicollet Mall in beautiful downtown Minneapolis, and I'm the moderator of Forum Fest. It's my pleasure to introduce this evening's guest speaker. Dr. Johan von Schreeb is a surgeon, a health emergency analyst, and a noted humanitarian. For over 20 years, he has provided medical assistance and disaster relief in Afghanistan, Sierra Leone, Democratic Republic of Congo, Rwanda, Sudan, Darfur, Pakistan, and most recently in Haiti. He has worked with Doctors Without Borders and with the World Health Organization, and he is the founder of Sweden's chapter of Doctors Without Borders. He's based in Stockholm, Sweden, at one of Europe's largest medical universities, the Karolinska Institute, which is also known for appointing the laureates of the Nobel Prize in Medicine. At the Institute, Dr. von Schreeb leads a team of researchers focused on bringing medical relief to disaster areas, particularly in developing countries. Tonight, he will offer his perspective on the recent crisis in Haiti and provide a deeper understanding of the obstacles, the challenges encountered in bringing health care to disaster areas around the world. We are honored that he has flown from Sweden to be with us tonight at Forum Fest. Ladies and gentlemen, please join me in welcoming to the Westminster Town Hall Forum, Forum Fest, Dr. Johan von Schreeb.
Thank you very much for that introduction, and thank you very much for inviting me to come here to speak tonight. I'm honored. It is easy, I think, to speak about assistance to populations in danger in a non-provocative way. It's easy to talk about all the good things you have done, etc. But that's not what I'm going to talk about today. I'm going to try to be provocative and challenging, because I think that's the way we can move forward. That's the way we can do things better. And I'm looking forward to an interesting discussion after my presentation. So I'm a medical doctor specialized in surgery, and since more than 20 years I've had the opportunity to work with MSF, Doctors Without Borders, or as it is called, Médecins Sans Frontières. It is a French organization, we mustn't forget that. It's called MSF, and I will relate to that. 17 years ago I started the Swedish branch of MSF and was its president for the first 7 years. And in my current work, I try to combine medical field work in disasters worldwide with research on how relief work can be better adapted to the needs of the affected population and to the context. I strive to develop evidence for better medical practices in disasters. And as was said earlier, I'm based at the Karolinska Institute. That is a medical university. And this year, Karolinska Institute celebrates 200 years of existence. In 1810, it was founded by King Carl XIII, because a third of all the king's soldiers that was injured in the war with Russia died in the field hospitals. The barbers, that were the surgeons at the time, were not good enough. So the task for Karolinska Institute was to improve the skills and better organize the barbers, and actually even introduce surgeons that was not initially doctors, they were initially barbers. So that's where I come from the barbers. I can clearly see the parallels to my research improving humanitarian health assistance after disasters. To put my presentation tonight into context, I would like to take stock on our common history, that of the immigrants. Vilhelm Moberg was a Swedish author that wrote 4 books about Christina and Karl Oskar and their families' endeavors when emigrated from Småland in Sweden to settle here in Minnesota. The book eloquently describes the context from where they emigrate, from poverty, misery, and lack of hope. They come here for a future that looked much more bright than that in Sweden at the time. During a 50 to 60 year period, starting around 1850, and actually that was the year that this church was funded, around 1 million Swedish people, 25% of the total population emigrated to the United States, and mainly to areas in Minnesota in search for a better future. Today, young people in search for a better future are trying to leave Democratic Republic of Congo, Somalia, and other devastated countries. On the shores of West Africa, they set out in leaking boats to try to reach the shores of Europe. But they are not welcomed like the Swedes were when they came here. They are rejected by the world. One event that triggered the departure for Christina and Karl-Oskar was when their barn burned down. They suddenly woke up one night to find the sky lit up by a fire. In nightgowns, they desperately fought the fire. They hurled water and tried to save what could be saved. Neighbors arrived with buckets. The disaster was a fact. Someone rang the church bell, and more people arrived to assist. But despite the efforts, the barn burned down. There was no 911 number to call, no fire brigade, and no insurance to claim. Neighbors that saw the fire and heard the church bell came to help, but those living further away couldn't do anything to help. Humanitarian assistance was geographically limited. It ended at the curve of the road. Without information or geographical access, it was not possible to help. But today we have information. Within minutes of an earthquake, it's possible to get a text message that defines the exact geographical location of the earthquake and the magnitude. Aeroplanes can depart rapidly and within 24 hours reach any place around the world. But does this mean that we have to help? That we have to do something? And what is our moral responsibility towards people affected in countries far away? What is our moral responsibility in this new globalized world? To help is to be active, and it's easy to know that water buckets are needed when the neighbor's barn is on fire, but it's difficult to know what a stranger affected by an earthquake needs. When preparing today's presentation, I had a working title, Lessons from Disasters Relief Worldwide. But I didn't know where to start. What message should I convey to you tonight? It took an email that contained a new title for my presentation to trigger me. The new title, Bringing Hope to Haiti, was presented to me, and it provoked me. It provoked me enough to get me started. But why was I provoked by this title? Well, for me it sends out a message that it is relief from outside that is the hope and the solution. More relief is equal to more hope. A message bringing hope to Haiti that conveys that it is the good guys from outside that is going to come in with hope to save the poor victims. Maybe I have deliberately misinterpreted this title, but my experience after returning from Haiti underlines that such view is common. The media has helped reinforce this image by portraying Haiti as hell on earth, and that the affected population are helpless victims or violent gangsters. The doctors arriving from the outside are the heroes fighting the dark forces of mankind. I do not subscribe to this view. In my experience, the ones bringing hope on Haiti are the silent Haitian majority that has stood up from the rubble and brushed away the dust. The neighbors that help each other, the women and men that despite poverty takes care of distant relatives that have become orphaned. People that against all odds continue to live their life. They are the heroes on Haiti. What does it mean to bring hope? Well, during my work in low-income countries, I have developed what I consider a healthy skepticism for what well-intended efforts from rich countries can do to solve problems in poor countries. History supports my skepticism. It is easy to be blinded when on a mission to do good. This can be especially noticeable when the intentions are for people far away towards poor victims that we know little about. When directed to people considered inferior, humanitarianism elevated to the rank of ideology reveals its profound ambivalence. And I would like to quote the French author Nodji, who a bit cynically wrote, "In the humanitarian relation, the power one holds over the other is absolute. It is this that allows the immediate transformation of a life machine into a death machine and vice versa. For the master, the punishment is inseparable from the gift. The providential function of the humanitarian ideology is profoundly ambiguous, as only providence, as its name indicates, has the transcendental power to feed and to kill, to lose and to save, to starve and to nurse, to destroy and to uplift." In my work, I've been trying to move away from glorifying the efforts of disaster relief. Humanitarian assistance is not heroic. It is purely an act to preserve human dignity. Humanitarian assistance has its fundamental starting point in the humanitarian imperative, which is a non-negotiable impulse. It is this impulse that makes us rush up to the lady that has fallen in the queue of the supermarket line to help her. We don't ask why we try to help her, we just rush there. We just do it. It is a non-conscious act that defines us as humans. But to guide humanitarian assistance, there is also need for knowledge and understanding of context. The context is the environment in which a disaster occurs. And after this presentation, you will get a small graph that illustrates context, and it's not possible to discuss it here, but I will refer to this concept of using socioeconomy and health as an indicator to describe context. And it's clear that the world has changed dramatically the last 50 years. We have to stop using old terminologies that divide the world into two parts, such as underdeveloped and developed world. They don't fit anymore to describe the world. Industrialized and non-industrialized countries. For example, China, is that an industrialized and non-industrialized countries? The concepts are simply not good enough to describe the diversity of countries that exist today in the world. A better way to divide the world is by their socioeconomic status. And if we look in the world, we can clearly see that there are at least three different groups of countries. There are low-income countries, middle-income countries, and high-income countries. And the health status of the population is linearly related to the socioeconomy. The richer countries, the more children survive. The poorer, the more children die. And in the world, if you look, the child mortality rate varies between 20% and 0.2%, a factor of 100 between the healthiest country and the non-healthiest country in the world, between the richest and the poorest. The Democratic Republic of Congo is a low-income country with very high child mortality. I've worked there. I visited a small rural hospital 2 hours outside Bukavu in eastern Congo. And to my surprise, I found a functional hospital. And in the main patient room with 30 beds, there were smiling, happy women lying with children by their breast. They had recently received a life-saving cesarean section. And I was very happy to see this. And as I turned to the hospital director to discuss with me, he didn't look happy. And he said, "We have not received any money from the government or any agency for more than 10 years. And we continued to talk and walked through the hospital, and we passed a rusty door. Curiously, I asked the director what was behind the door, and he swung it open, and inside, in a very small room, there were 3 ladies lying in 3 old beds, each of them with a baby at their breast. And then I asked the hospital director what these women were doing here. "Oh, they have received a cesarean section, but their treatment is finished now." So then I asked him, "So what are they doing here if they finished their treatment?" "Well," he said, "they haven't paid their bill." So then I asked him, "How long have they been here?" 3 months. He said, we cannot be charitable. We don't have any money. We just have to get the money from the patients. Otherwise, we have to close the hospital. This is the fact. I mean, I would like to give free care, but it's simply not possible. And I nodded, and then I reached for my wallet, and actually I had $120, which was the cost for 3 C-sections, because it was $40 each. And then I gave it to the women, and they were very happy to be released. But as I turned around, there was a line of coughing old men with TB, others with crutches, waiting to be released from the hospital. And this is a fact around the world, that today healthcare is not something that is affordable for many people. And the lack of capacity to pay for healthcare constitutes a major challenge for populations. And poverty induced by healthcare spending is a growing disaster. And in order to provide disaster relief, we have to have an understanding of the health system in order to plan better for the assistance. A disaster can have a sudden or slow onset. It can be due to man-made or natural causes. And a disaster develops when a hazard meets vulnerability. And the main determinant for vulnerability is the socioeconomic status. This means that the disaster can be avoided if vulnerability is reduced. If an earthquake of a similar magnitude, as the one on Haiti, had struck San Francisco or Tokyo, we would not have seen as many casualties, maybe not even any. However, it would have been very costly. The likelihood of dying in an earthquake in a low-income country is 100 times higher than if a similar earthquake affects a high-income country. And this is well illustrated by the strong earthquake that struck Chile in February. And I don't know if you remember, but about 1 month after the Haitian earthquake, the Chilean earthquake struck, and again it was earthquake on the media. And this time it was 100 times stronger earthquake than the one on Haiti. And the media message was clear, devastation in small cities traveled, images of devastation traveled all around the world. And everybody said, is this another Haiti? But it doesn't take rocket science to understand the differences in vulnerability between Chile and Haiti. Chile has a gross national product per capita that is more than 10 times higher than that one of Haiti, and child mortality is 10 times lower than Chile. Actually, Chile has the same child mortality as the United States, so Chile is more of a high-income country. And Chile had enough resources, doctors and helicopters to handle the consequences of the massive earthquake. MSF sent a team to assess the needs. They could quickly conclude that outside assistance was no more needed. International humanitarian assistance takes place in a legal vacuum. There are no international laws that guarantees that an earthquake-affected person on Haiti has any right to international assistance. There is no international 991 number to call, no agency to take responsibility besides the government of the affected country. If Sweden or United States decides to send blankets or doctors to Haiti, it is purely on a voluntary basis, either as an act of humanitarianism or as a political sign, or maybe both. Studies have shown that the level of humanitarian assistance is more based on the geographical interest of the affected country than on the needs of the affected population. In August 2008, Russian troops invaded South Ossetia in Georgia. A few hundred died and people were displaced because of the fighting and bombing. There was political tension between Russia and the outside world. It was a political rather than humanitarian crisis. Nevertheless, the outside world wanted to help the affected. Hundreds of freight planes loaded with medicines and material arrived in the capital, Tbilisi. The Swedish government decided to send 5 ventilators, and I was asked to assess the needs for more assistance. As I attended a UN meeting, I got a bit tired of the discussions and decided to leave early and stepped outside to smoke a cigarette, which is a very bad habit I have when I go on missions, I have to admit. And as I was inhaling the first part of the cigarette, I saw another man stepping out of the same meeting, and he came to me smiling, looking happy because he had a friend to smoke with. So I lit his cigarette and we started to discuss. I introduced myself and my mission, and then he laughed and and told me who he was, and he was actually the Minister of Health. So I was sharing a cigarette with the Minister of Health, which is almost made me laugh. But it also gave me the opportunity to discuss something, in between four eyes about the situation in Georgia in the height of this disaster. So I asked him, so what is the situation? And he said, it is terrible. And I was thinking, oh, there must be a lot of dead people here. It must be a very difficult situation. And then he said, we have received more than 15,000 surgical kits. It will last us 10 years. In addition, there are boxes with 6 million syringes and needles. We have to rent storage to keep up, to store all this material. Because if all this material gets out, the market will be destroyed. So it wasn't the wounded or the displaced that was the problem for the Ministry of Health. It was all the material that was sent there. So sending material and medicines without assessing the needs and understanding the context is often wrong and may create more problems than they solve. But medicines are an amazingly strong symbols of help. And we can see that everywhere in the media, that sending medicine is the instinct, it's the knee-jerk reaction that people do when there is a disaster. And besides this assessment, I also found that actually Georgia has twice the number of doctors per capita compared to Sweden, so there was no need for doctors. In 2008, I worked in Haiti to assess the needs after the typhoons that struck the country. I also did a study on the health system. The patients in Haiti had to rely on the aid provided by the 400 Cuban doctors working in the country. Lack of healthcare, bad governance, high vulnerability and poverty was the context in which the powerful earthquake struck. And for the first time in history, a densely populated capital was affected by a large and strong earthquake. This in combination made the effects of the earthquake devastating. Bringing hope to Haiti. Yes, Haiti needed massive outside assistance. 1 hour after the earthquake struck, night fell. And you can just imagine, there was no electricity. There was dust in the air. There were people screaming from everywhere, being caught under the rubble. And as night set, the number of screams diminished as people were dying under the rubble. It was pure horror. MSF, Doctors Without Borders, has been working on Haiti since 20 years and has been running 2 hospitals. Both of the hospitals were severely damaged by the earthquake, and staff was caught under the buildings and staff died. The surgical needs were enormous. A few days after the earthquake, I arrived to work for MSF and set up a field hospital close to the epicenter. In my team of 20 people from 14 countries, including Cameroon, Rwanda, Brazil, Peru, we worked day and night to operate and to care for the injured. However, there were huge problems of coordination between the agencies providing relief. The head of United Nations on Haiti died in the earthquake, and the UN was paralyzed for the first few weeks. A problem was the lack of knowledge and experience of those arriving from outside. Setting up and running a surgical unit in a disaster context requires a machinery. It requires logistics, electricity and water, a place to sleep and food. Too many doctors arrived with a mission of less than a week or so, with a bag of medicines and surgical instruments. Many of them were obviously disappointed because there was not a lot for them to do. They had no place to work, and they hadn't prepared themselves, and they returned home with an incompleted mission. There were lots of good intentions, but the difficulty of disaster relief became painfully obvious, and without proper organization and knowledge and experience, these good intentions didn't materialize in efficient results that served the affected population. Doctors Without Borders, Médecins Sans Frontières, was formed in 1971 by engaged young French doctors that wanted to change. MSF still combines medical work with témoignage, which is bringing witness about atrocities and violations of humanitarian principles. MSF's first-handedly watched and spoke out against the inability of the international community to protect civilians against being massacred in Srebrenica in Bosnia in 1994. And MSF watched Tutsis being killed during the genocide in Rwanda and became painfully aware that doctors cannot stop a genocide. Currently, some 10,000 doctors, nurses, and local staff from more than 70 countries work together to preserve human dignity and to save life. MSF is not based on charity ideals, but on ideals for a change. And for change. It is based on humanitarian principles and medical ethics. And it's clear that MSF is not the solution to human suffering caused by disaster. The solution lies elsewhere. But MSF is one expression underpinning the belief that if there is a human right to have access to healthcare when needed, whether it's among earthquake affected in Haiti or illegal immigrants in Sweden. MSF is responding to system failure and loudly pointing out that governments should assume their responsibility. It is the world's largest independent medical relief agency. To conclude, I would like to summarize by a few words by the author Joseph Conrad. More than 100 years ago, he wrote, "Left alone with his own weakness, man is capable of anything. If we believe in mankind and a civilized world, we cannot leave disaster-affected people alone. We can't turn away and say that we don't care, because we know the information is out there. And the consequences of looking away and such behavior will endanger our own future on this planet. I'm convinced that we can do more and that we can do much better. But to achieve this and to be successful in our work to assist disaster-affected population, we have to be we have to be using not only the warm heart, but also using the cold brain. And together, that should help us to do a better work. Thank you very much for listening.
Thank you, Johan von Schreeb. You're listening to Forum Fest, the Westminster Town Hall Forum's new summer series, broadcast from Westminster Presbyterian Church on Nicollet Mall in downtown Minneapolis. I'm Tim Hart Anderson, Senior Minister at Westminster and moderator of Forum Fest. Our speaker tonight is Swedish surgeon and humanitarian Dr. Johan von Schreeb. Now, while the ushers collect questions from our in-house audience, I would like to invite you to join us for the remaining events at Forum Fest and for our fall town hall forums. Information on upcoming programs can be found at westminsterforum.org. And now, Dr. von Schreeb, if you would return to the pulpit, I will present the questions from our audience. First question, could you tell us a little bit more about your experience in Haiti? You said you arrived 4 days after the earthquake. What exactly did you find and what did you do?
Well, our plan was to fly into Port-au-Prince, but that was impossible because the airport was overloaded and it was not possible to get landing permission. So we arrived in the Dominican Republic, and then with the car we managed to get to Port-au-Prince during 4 or 5 hours, and it was total devastation. So we met up we were about 15 of us arriving together, and we met up with a team of MSF that had been there during the earthquake, and obviously they were shocked and they were tired, and they had tried during the first day when everything was chaotic to do something. And then we split up. There were 4 hospitals set up, and I took charge of one that was set up more close to the epicenter. And we erected together with and employing local doctors and nurses. So we employed about 100 people during the first few days. And then we erected tents, because MSF this is really their specialty. Everything is pre-packed in containers, and they are stored on the large airports around Europe, and they can be flown immediately and be transported rapidly. So we have kits for 25 operations that can be used immediately. And of course, the principles for conducting war surgery, which it was, even though it wasn't a war, but the same principles should be used, meaning that the wounds are infected, you cannot close the wounds, you have to leave it open. The anesthesia you use, it's extremely simple anesthesia, which is, in our part of the world, it's used for veterinary medicines, but for war surgery it's appropriate because it's safe. And we had 4 operation theater in my hospitals, and we were working basically day and night because there were so many injured. And then quite rapidly, only after a week or so, the number of casualties rapidly decreased. And that you see normally in disaster situations, how quickly the situation normalizes. And immediately the need for cesarean section, for example, increased. So only after week 10 days, the major operations we were doing were C-sections. And, coming back to the health system and the problem of the failed health system before, we saw a lot of untreated chronic conditions such as breast cancer, etc., that had not been taken care of prior to the crisis because people didn't have money to pay for it. So it was very hectic. It was a fantastic collaboration with the local Haitian doctors and nurses. And this hospital is still running, but of course, it has to be over time, the resources are going to be used elsewhere, but for the time being, it's still needed there. But the immediate needs are covered for the time being. But now, of course, there are different challenges for the Haitian population with typhoons, etc., lack of shelter and lack of money and lack of employment to work and lack of ways to earn your living. And obviously, it's easy for a whole community to be dependent on outside aid.
And what kinds of things were you doing as a doctor on the ground in Haiti, and were you working collaboratively with others in Haiti or on your own?
Well, that was one of the main problems, how to collaborate and what to do. And it's clear that it should be the role of United Nations when in a collapsed society to coordinate the work. And as I told you, the United Nations was down on their knees. They weren't capable of coordinating. And everybody basically was busy with their own patients that were in their compound. And a lot of other agencies referred patients to our hospital because at the time we were the only stable hospital that had possibilities for people to stay overnight. And my role was initially to do surgery, but I was there as the medical coordinator for this hospital. So it was to set up the hospital, make it function, ensure that the 50 beds we had were used properly, and that we had the equipment necessary, we had the doctors. And immediately the beds were filled, so it didn't take more than a few days until we had 20 patients with fractures of the femur, which is a very complicated condition that needs special care.
And how long were you there in Haiti at that point?
I was there for 3.5 weeks, and then basically the first phase was over, and it was a new. And also, I think it's the lesson from working in this type of settings is after this time period, you're very tired because it's a full-on 24-hour experience.
Can you tell us something about the collaboration with other NGOs? Are there too many NGOs in a place like Haiti when there's a disaster and the complication that results from that?
Well, we always see that the problem with international assistance is that there is no legal framework for who can work and who cannot work. Everybody comes with their own mandate. Everybody wants to do what they have decided to do. If one agency has decided they want to work with children, they can do so, even though there might be more need for the elderly, etc. So that is really a challenge for the humanitarian endeavor in disasters to ensure that everybody gets help and that the help is divided among those that are there to provide it. But again, if you don't have if you don't have a whip, you can't tell anybody what to do. Agencies will still continue what to do. They have their backpack with the money and their mandate from back home, and they do as they please, and that is really a main challenge. For MSF, which is the world's biggest independent agency, we try to collaborate, but it's more that agencies send patients to us than we are actively collaborating with others. And I think also MSF has a long tradition of not participating in a lot of these solutions. Like in Afghanistan, the NATO the head of NATO said recently that he was upset that the humanitarian agencies didn't collaborate with NATO to help the population. NATO wanted to set the agenda. And the legal framework there is for international assistance is actually for that in conflict, where it claims that to be a humanitarian you have to be independent and you have to be neutral and you have to be impartial, which NATO cannot claim to be, but still they want others to follow them. And MSF strongly protests about that approach and strongly takes a distance from that approach. Otherwise it's impossible to provide assistance to those that mostly need it, rather than to become a part of a political process.
Is MSF still involved in Haiti, and if so, how long do they expect to stay?
Well, they've been there for 20 years, and I'm sure they will be there for another 20 years.
And what are the greatest needs in Haiti now? What do you see as MSF as going forward, the greatest place of need?
Well, when we talk about Haiti, we have to understand what it looked like before. And I was surprised now coming back after the earthquake to see that maybe some of the destruction was not due to the earthquake, it was there before. And of course this is challenging to see, and I think everybody now is very eager to change Haiti. And I think we have to be very cautious to travel too quickly. We have to give Haiti at least 50 years. We have to give it a generation. And by doing so, we have to do it step by step. And the work that MSF can do is to help train nurses and doctors. We can help, provide assistance such as they do at the maternal health hospital. We can start advocating for assistance, for that more people should receive HIV medications, that those with malaria receive the correct treatment, etc. I think MSF has a very strong voice when it comes to setting the agenda for the health policies in a number of countries worldwide, and I think this is what MSF will do on Haiti, while still continuing to provide emergency surgery. MSF is running since 15 years back one of the only trauma surgery unit in Port-au-Prince, and they continue to come in gunshots and traffic injuries, and that will continue. But hopefully, and it's run now only by Haitian surgeons and Haitian orthopedic and general surgeons. So there are no international surgeons there. They manage quite well by themselves. It's only supported by MSF, and this gives hopes for the future.
You mentioned there were 400 Cuban doctors in Haiti when you arrived. Did you interact with them? And there are a lot of Minnesotans interested in cosas cubanas, Cuban things. Can you tell us about your interaction with the Cubans there, or perhaps elsewhere?
Well, I think this is a very interesting something that's neglected and not at all talked about and not at all written about. Maybe in the United States there is a political reason for it, but for the rest of the world there is no reason for not discussing and highlighting the efforts of the Cuban doctors. And I'm currently involved in a research project where we are working with a Cuban institution and looking specifically on the earthquake in Kashmir 2005, where I worked also. And actually the Cubans sent over 30 field hospitals to Kashmir at the time. And some of the doctors I've met when I was in Cuba recently said that they were basically told from one day to another to leave to go to Kashmir, and then they were gone for 7 months. You couldn't find a Swedish surgeon that would accept to be sent away for 7 months. And of course, I mean, due to the political system, this is possible, and it is maybe not so obvious that this can be replicated elsewhere. But I think the principles and the low-tech approach that they use, the Cubans, it is very well adapted to disasters in both low and to a certain extent middle-income countries. And Cuba is constantly has its disasters with typhoons, etc. So I think they are in a very, very good position, and they have doctors elsewhere. I think it's about 25,000 Cuban doctors all scattered around the world, so they have a lot of experience.
Any particular encounters with Americans in Haiti in responding to the disaster that you care to share with us? Did you meet with Bill Clinton, for instance, while you were there?
I was busy in the operation theater.
What about mental health needs in a disaster setting? How do you deal with the mental health issues that are in those who've experienced trauma like this?
This is a very important topic, and one that the last 10 years has grown as an issue in disaster situations. And MSF has developed a very strong policy when it comes to responding. And in my team, there were 3 psychologists and 1 psychiatrist. And obviously, when you respond to mental health problems, you have to have a very good knowledge of the situation. You have to understand the context extremely well. And especially in Haiti, with the voodoo and everything that's around it, it's not so easy to come from a Swedish psychological, or from the office of a Swedish psychologist and think you can interact and know what the problems are. You have to be extremely generic. You have to work in groups, and you have to have and not go too much in deep. And it's been interesting to follow the work as I worked in Kashmir, and then I also did an evaluation in Darfur quite recently on mental health support. And it's interesting to see that it really relates a lot to psychosocial support. I mean, if we feel safe, if we know that our children are safe, if we know we have a roof that we can sleep under during the night, if we know that there is food and that we are not threatened, then a lot of these mental health consequences can be avoided. So I think one of the priority for mental health projects is to ensure that the psychosocial support is functioning, rather than trying to medicalize a normal reaction, which is usually is. We talk about PTSD, post-traumatic stress, etc. I think we have to leave that for the time being and focus on providing comfort and ensuring stability for the affected, and that will probably have more impact than immediately rushing out and trying to treat it as a medical illness.
You spoke about the importance of understanding the context when you go to deliver humanitarian aid or disaster assistance to a particular area. Can you describe a time when your team misjudged the need or misunderstood the context, and how you adapted with that situation with limited supplies, lack of time, or a misunderstood context?
Well, I think there was one which is more of a middle-income setting, but you remember the 2004 Beslan incident when the school was taken over by a group of terrorists, and children became hostage, and it ended up with 600 people being killed. And then it was not with MSF at the time, it was through the Swedish National Board of Health and Welfare that was asked by the Russian government for assistance. So they wanted to send things to this part. So instead I said, I'll go there myself to see if there are needs for trauma surgeons, etc., because that's what they were talking about. And I traveled there, and immediately I could see that within 20 minutes from this hospital, and I didn't know this before, there were 4 big hospitals. 20 minutes from this school, there were 4 big hospitals. And there were over 2,200 beds in these hospitals, I mean, during normal times. And there were over 900 doctors, of which 500 were ready to care for the wounded. So there were about 1 doctor per injured. And I was thinking, oh, what about the surgical experience of these Russian surgeons? Maybe it's not so good. So then I came into the mornings, all the surgeons in the morning drink coffee together. That's probably an international thing that I've learned. And also all the surgeons note down what they do for their history. They want to show what they have done, how many operations they've done, etc. It's very important for surgeons to do this. And I can say that as a surgeon, otherwise they would shoot me. But anyway, when I came into their coffee pause in the morning, there were about 10 or 15 surgeons there talking, and they all were wearing their chef hats. It looks very interesting. And then the door opened, and then the head of this clinic at this major hospital came in and asked me what I was doing there. So I was trying to explain to him I was there to do this assessment, etc. And I was saying, so what is the situation? So what have you done? He said, well, I am a surgeon. Oh, where have you been? Oh, I've been working in Afghanistan. Afghanistan? He said, that's interesting. Where did you work? So I worked outside Herat. Herat! I was also working there. When were you there? So I say I was there in 1989. 89! That's when I was there too. On what side were you? And then I had to sort of, drift away from the topic, because he was working for the Russian army, and I was with Mujahideen, with MSF at the time. So we were but we became very good friends. And it turned out that more than 20 of the surgeons, more than 50% of the surgical faculty, had war surgical experience. In Sweden, at the major university hospital, at Karolinska University Hospital, there's one surgeon of 60 or 70 surgeons that has war surgical experience. So we concluded in the study that there would be no difference in casualty or the number of people that would have died in hospitals if the same type of disaster would have affected Stockholm would have been no different compared to Russia. They were more than capable than the Swedish surgeons. And that's an example of context. I think otherwise there are a lot of other examples of lack of capacity to do a good needs analysis of the situation. And usually it comes to underestimating the capacities of the local doctors and nurses and those around. That's usually the main problems we do. We underestimate their capacities and their willingness to do, and I think that's a shame. I mean, a primary health care doctor in Congo knows more of the common surgery that needs to be done in an African context compared to the Swedish general surgery. I mean, an African general practitioner knows how to do a C-section, to do a splenectomy, and knows how to take care of complicated deliveries and fractures, when a Swedish surgeon does not. A Swedish surgeon is good on doing laparoscopic surgery, but has no clue of doing these other operations. And that lack of capacity and lack of analysis of the context, I think, is the main problem that we have.
Picking up on that comment, does the highly specialized nature of training of doctors today, surgeons for instance, make them less useful on the field in a disaster because of their specialty?
Absolutely. I mean, a surgeon must be able to do a C-section. It's almost impossible today to find a general surgeon that knows how to do a C-section. At least in Sweden. I don't know what's like here, but I would think that it's the same situation here. So we have to retrain them. We have to send them for more training. And even in Sweden, the Swedish surgeons now go to South Africa to learn trauma surgery because we don't have any more traumas in Sweden. You know, we have 320 people that die in car accidents, while in Nigeria they have 50,000 people that die in traffic accidents. So trauma is basically extinct in Sweden. And of course, trauma surgeons need to have practice. Without practice, they don't know how to do the job.
Doctors Without Borders was made to leave Darfur. What happened? How can the situation be remedied in that area? Any comments on your work there?
Yeah, that's an interesting one. You know, if you look back in history, MSF has been kicked out of certain countries. In 1985, MSF was kicked out of Ethiopia when they openly said that the government was using food aid for political purposes to move people from one area to other. The food was being used as a bait to get hold of insurgents and to get hold of young men and to transport them to other parts of the country. And this was true, and MSF spoke out about it, but they were kicked out. And later, it took 6 months or so before the international community reacted and spoke out with a strong voice, and this displacement stopped. In Darfur, it was something else. I mean, MSF had been in trouble before in Darfur because they had been openly speaking out about the terror against the civilian population, about rapes, etc. So MSF was already not on very good speaking terms with the government in Khartoum. And then when the President Bashir was brought on trial in The Hague, it was just a few days before I arrived there, MSF was kicked out of Darfur, together with a number of other NGOs, as a response to the international community, rather than as a response directly towards MSF. At the time I was there for WHO, so I could still travel around. But it was clear that the work that MSF and the other agencies that were expelled from Darfur was not being filled by the government, even though they were trying, at least for the first month. So the situation in Darfur is of course extremely bleak. But it's always like that. The world can only handle one disaster at a time. So when Haiti came, Darfur, the spotlight on Darfur disappeared. So we will see when it can come back again in highlights. There will have to be something that fits the media format. But because if it's something today in relation to disaster, it's the media that decides a lot where the next, where more aid should be delivered, because they decide on They need images, they need good images, and they need good stories. And very often we follow what they say, which is, I think, shameful. I think the needs of the population should be able to stand out as the ones directing where we go and what we do, not the media. The media shouldn't point out where the international community is putting their efforts.
Are there differences in the kind of response needed to a natural disaster as opposed to a disaster made by human hands? And if you can say so, which would you prefer to be responding to?
I think a natural disaster is much more clear-cut. You have a start, and then usually you can project very much what the needs will be. We have developed something we call remote magnitude assessment or assumption, where we, within hours, have managed to predict very much what the needs will be. While in Darfur, we know there are chronic needs, there are needs related to the political situation. And I think in a lot of the man-made disasters, the humanitarian assistance is not the solution to the problem. And I think it's important not to serve as the fig leaf for strong political power, for doing what the politicians should be doing, for doing diplomacy, etc. I think very often humanitarian assistance, as I said, in Georgia, was used very much to cover up for lack of political ambitions, and I think humanitarian assistance shouldn't do that. So I think there's a clear distinction between the sudden and the more slow onset. I think what is very interesting is hunger crises. We don't call it famines anymore. It's more called hunger. And the problem relating to that children are malnourished is usually not a lack of food, but it's a lack of capacity to pay to buy the food. Usually a market failure that the prices of food has gone up very quickly. And we saw this in Niger in 2006, 2007, when suddenly there were more children malnourished, and people were discussing whether to bring in food rather than analyzing the problem to understand what the causes were. And there were, of course, a lot of different causes. There were political failures. There were people were exporting the food because the prices were lower or were higher in neighboring countries, and et cetera, and then the income of the population had gone down. So actually it was not lack of food, it was lack of purchasing. And this is important to analyze that when you respond to the different crises.
And as a final question, can you tell us, Dr. von Schreeb, what is it that motivates you to do this work?
It's meeting the people out there, and it's learning more, because I learned so much from meeting people around the world. And obviously, there's it's good to work with people, and it's good to work together to try to solve problems. But it's also important to know that you are not there to solve the problem, and I think that's. I think some colleagues that started out became a bit cynical by, they're saying, what's the use of doing that? But it comes back to your expectations. What are our expectations on mankind? Is it that we should have peace on earth and that we shouldn't be angry and fight, there should be no wars? I try to be more realistic, and I'm just sort of happy by the fact that 95 or 97% of the population are nice people that can sit together like this without hitting each other, that can go to work in the subway or even sit in line with the cars going to work, or end up in refugee camps without hurting each other. But these silent people never get a voice, these people that really are the backbones of humanity. And it's fantastic to interact with them, and they, I think, definitely the hope for the future, not the other ones that we know will be there all the times, the one making the problems. But obviously, the ones making the problems are the ones that gets the attention and that we focus on. Let's focus on the other ones instead, that are the positive ones.
Thank you, Johan von Schreeb.